Hi, this is Dr. Stanley, and this is one of our series of quick medication facts. We are going to learn today about selective serotonin reuptake inhibitors, also known as ssris. So, hopefully, by the time you're looking at this medication fact, you probably have a little bit of an understanding about neurotransmitters and the role that they play in the body of transmitting signals and how they can affect the mental illness or mental health of an individual. So, when we're looking at selective serotonin reuptake inhibitors, they do target the neurotransmitter serotonin, and that's part of the title, so it should be easy for you to remember that. Basically, what they do is they block the reuptake of the neurotransmitter serotonin, making more bioavailable in the neurosynaptic gap. And when there's more bioavailable, then the transmission of impulses between these neurons can actually occur because we have this, chemical messenger that is going back and forth, and there's enough that's present to be able to allow this to occur. Now, interestingly, the neurotransmitters norepinephrine and serotonin have been linked to playing a major role in the regulation of mood. And when there is a transmission deficiency of this monoamine neurotransmitters within the limbic system, it is believed that they may be the underlying contributor or cause of depression. So there is a hypothesis out there, and there's some other ones that are talked about in your book as well. But the hypothesis is that a deficiency in one or more of either serotonin or norepinephrine or dopamine is going to cause depressive types of symptoms or other types of mental illness. And so, if there is a deficiency that is present and we address it through the medication, then the depression is going to improve. There is also some suggestion that low levels of neurotransmitters do cause this thing called postsynaptic receptors to be increased in sensitivity and number. And so increasing the amount available is going to eventually downregulate or desensitize these key receptors. And this is going to take a little bit of time for your body to kind of step that back down. So basically, because it was low, gave it this increased sensitivity and number, and it's going to have to step back down in order for things to be effectively working. And so that time to down regulation, they believe, may explain that 4 to 8 week time it takes for the antidepressants to begin to work. So unlike other medications where you do something like, hey, I went ahead and I took my cardiac medication, my blood pressure medication, and so my blood pressure was lowered within the next hour. When you're talking about depression and taking antidepressants such as SSRIs, it takes several weeks before you start to get those effects. So this slide seems almost a little redundant, but just to clarify, how do these medications work? SSRIs do block the reuptake of serotonin, making more bioavailable in the synapse. So basically, you think about these serotonin kind of like transmitters, and they transmit their signal, and then usually they're taken back up and they're broken down and new ones are produced. But because there just aren't enough in individuals who are suffering from depression, what we do with the medication is we keep them from being taken back up. So they stay there in the neurosynaptic gap to be able to transmit new signals. This is the first line of treatment for a major depressive disorder and most anxiety disorders as well, because some of the other medications like benzodiazepines for anxiety disorders are not ones that you want to use long term because they do develop a tolerance and they require more and more to do the same thing and all kinds of other problems as well. So when it comes to side effects from the selective serotonin reuptake inhibitors, some of the common side effects are nausea, restlessness or jitteriness, sleep disturbances, and sexual dysfunction. And that sexual dysfunction can take on the form of apathy about having sex, a low libido or desire for sex, and it can greatly impact the individual's ability to achieve an orgasm as they previously did. The other thing that can occur, of course, is erectile dysfunction. That is something that is a side effect as well. So consider this slide kind of these are the SSRIs, but also ones that are more specific for certain things. And so the first one we're going to talk about is fluoxetine, also known as Prozac. And it is the most activating, and it causes nervousness and insomnia. It does have a really long half-life, so with elderly individuals or those who have, liver hepatic impairment, or they will be more susceptible to the activating effects of fluoxetine. Sertraline, also known as Zoloft, is one of the most common, and it does cause the most GI distress in the form of diarrhea. Fluvoxamine or Luvox is the most sedating, and so in that case, we should be administering that one at bedtime. So, interestingly, if somebody has problems with sleep disturbances, which is common with major depressive disorder, this may be one that kind of is a 2-for-1 when you take this medication because it may help you actually sleep, but then it may also give you that wonderful antidepressant effect that we need through more serotonin being bioavailable. The next one is paroxetine, also known as Paxil. It is the most anticholinergic due to the muscarinic 1 receptor antagonism, and so it's not ideal for patients who have contraindications to anticholinergic agents, such as those who have things like narrow angle glaucoma. The next one is citalopram, and this is often used not only as an antidepressant, but it also has some ability to achieve pain control for those who are suffering from fibromyalgia. One of the problems with Celexa is that it does tend to cause a prolongation at times in the QT interval. Of course, this is going to be dose dependent, meaning the more you give, the more likelihood of a prolongation of the QT interval. And when you're talking about a prolonged QT interval, I know you guys haven't had critical yet, but when that QT interval is prolonged, it makes you more likely to kind of like go on into a fatal type of arrhythmia, and you'll learn more about that in critical care. So we do want to use this with caution in patients who have electrolyte disturbances because a lot of electrolyte disturbances also are going to alter that QT interval, making it worse. So, for example, alterations in potassium, it can be a problem there. So anyway, those are a little bit about the specific SSRIs: fluoxetine, sertraline, fluvoxamine, paroxetine, and citalopram. Now, this is a pretty busy slide, and so I do want you to pause here and maybe kind of study it for a few minutes. But let's first talk about the nursing specific thoughts. These are some things that are important to understand about administration of SSRIs. Number one, there is an increased energy that tends to occur with SSRI administration about 2 weeks after beginning the medication, but there's no increase in like the mood until about week 3 or 4. So imagine you have somebody who's very, very depressed and they, have suicidal thoughts, and all of a sudden they have lots of energy, but they still have a mood that feels like crap. So what would you think would be the likelihood that that individual at that point may be like, okay, now I have the energy to complete my suicide? And so this is why somebody is more at risk for suicide 2 weeks after starting an antidepressant. And interestingly, antidepressants can cause suicidal thoughts in and of themselves. I've had patients before who started on the antidepressant. They were like, well, I was depressed, but I didn't have suicidal thoughts until I started on it. And this is part of the reason we tell them, be sure and tell your practitioner if you start to have suicidal thoughts or if they start to increase. So 2 weeks out, increased energy, suicidal thoughts is not a good combination. So that's something we really need to step up our game and watch for with those patients who are still there after 2 weeks, or we need to notify their family that this is a possibility. Interestingly, as much as 70% of individuals with bipolar disorder are initially diagnosed with depressive types of symptoms. So basically, what that means is somebody who's bipolar tends to be, and I know we haven't had that yet, but a bipolar patient tends to be, depressed, and then they can become manic. And so what happens is when you treat their depression, you're going to send them into mania because of the fact that they kind of are at these two ends of the spectrum. So one of the risk factors for giving SSRIs is the idea that you can kind of kick your patient on into a manic phase, and that can be quite dangerous for them as they engage in very risky behavior that we will talk about when we talk about bipolar disorder. It does interact with a lot of other meds. SSRIs are known to interact with a lot of other medications. And so we have to be very careful with over-the-counters, with herbal, supplements, and make certain that our patients understand that you need to check with your pharmacy or provider before you take anything because of all the interactions that can occur with antidepressants. We want to teach them to avoid alcohol. We want to teach them not to drive until they know how they respond because some people do become more sedated. There is a risk in the elderly, especially for orthostatic hypotension. So a lot of times I will teach my patients, hey, when you stand up, just hang on to that chair for a minute until you know you're okay to walk because the last thing we want to do is give them medication that causes a sudden drop in blood pressure when they stand up and we see somebody fall and break a hip because that can be a life-ending event for some elderly individuals. We don't want to stop it abruptly either because it can lead to serotonin withdrawal. So it's important to tell our patients, hey, if you decide that you don't want to take this anymore, please let your provider know because we want to step that down gradually. If you don't do that, this is what the chart on the right is about. You do have some symptoms like flu-like symptoms, fatigue, weakness, tiredness, gait instability, ataxia, dizziness, lightheadedness, vertigo. All of these things can occur as you withdraw from the medication. So for our last slide, let's talk a little bit about a very serious adverse reaction that can occur with our patients as they are receiving serotonin-based agents. So, we have selective serotonin reuptake inhibitors. We also have MAOIs. We have a lot of different types of antidepressants. Most of them target serotonin. And serotonin syndrome tends to occur when they're on large doses or there's a large dose change or when somebody's on more than one of the serotonin type of agent. So for example, let's say that you have a patient who's on a SSRI, but then they're also drinking herbal teas with St. John's wort, which also targets it. This is part of the reason we have to warn our patients, hey, you need to be certain that you talk to your practitioner about any sort of changes that you're going to implement, any herbal or over-the-counter agents. Serotonin syndrome is a pretty serious life-threatening condition, and what we will notice and assess in our patients if they're experiencing serotonin syndrome is either hyperactivity or restlessness, and we might see an inner restlessness that's also known as akathisia. We might see tachycardia. We're going to see a fever, and this fever, if left unchecked, can produce hyperpyrexia. We'll see an elevation in blood pressure. We'll see delirium. That's a sudden onset, so we'll see that altered mental status. The individual will tend to become irrational and have wide mood swings. We may see seizures. We will probably see incoordination or rigidity of the muscles. We'll see abdominal pain and even apnea, where the individual can have periods where they stop breathing and eventually lead to a full respiratory arrest. So in order to intervene in serotonin syndrome, the very first thing we want to do to respond is to remove the problem agent. Obviously, if we're giving serotonin and they're in serotonin syndrome, probably not a good idea, so we want to remove the problem agent. And then we're going to treat them symptomatically. So when we're talking about symptomatic treatment for somebody who is experiencing serotonin syndrome, we're going to give them propranolol to control the blood pressure. We're going to manage the fever with cooling blankets and chlorpromazine for hypothermia. We're going to give them serotonin receptor blockade medications such as this antihistamine, cyprohepatidine, and methotrexate. I don't say these very well. And then we're going to give dantrolene, which is going to help relax the muscles because there is that muscle rigidity. We might see them also give diazepam, which is going to control seizures and also that muscle rigidity. So these are in that class of benzodiazepine. We might see anticonvulsants given like valproic acid or something like that. We are going to see artificial ventilation if their ability to breathe is impaired and they're experiencing that apnea. And we may even see an induction of paralysis until we're able to remove that offending agent entirely, process it through the system. So anyway, this is something to be aware of that can occur, and you're going to look for this when you see multiple serotonin agents or high dose